Welcome to the deep dive. Today we're tackling something absolutely core for neurosurgical practice, a really deep understanding of the brain's ventricular system. We've got some dense material here, aiming for that elite level of mastery.
That's right. And it's not just academic. Having a solid 3D map of these CSF spaces in your head, well, it's fundamental. It's about safety. It's about effectiveness, day in, day out.
So why dedicate a whole deep dive just to the brain's plumbing, essentially? What makes it so critical?
Well, look at the conditions involved. Hydrocephalus, that buildup of CSF, is probably the most common disorder neurosurgeons face. You have to know this system inside out to manage it, whether it's, congenital or happens after a tumor, an infection, trauma, even a stroke or hemorrhage. It's just everywhere in the clinic.
And surgeons aren't just reacting to problems in the ventricles, they're actively using them, right, as pathways.
Exactly. They're like natural corridors.
Mm.
Surgeons can navigate through these cavities to reach deep targets, tumors, vascular issues, ideally, without cutting through healthy brain tissue. It's about using the brain's own geography to stay safe.
And I imagine with newer technologies, this internal map becomes even more vital.
Oh, absolutely. Think about neuroendoscopy. It's completely changed things. Surgeons are guiding tiny cameras and instruments inside these spaces now, so you can't just rely on external skull landmarks anymore. You need instant recognition of what you're seeing inside the ventricle, the bumps, the ridges, the landmarks, to know where you are and where you're going, especially for things like ETV, endoscopic third ventriculostomy.
Okay, so to frame this for everyone listening, the source material really keys in on 4 core procedures that demand this knowledge. The basic but critical cannulation of the lateral ventricle.
Yep, the EVD insertion.
And the more advanced endoscopic third ventriculostomy, or ETV. And then the open surgical strategies, the different approaches to get into the third and the fourth ventricles. We'll build up the anatomy needed for all of those.
Sounds good. Let's start right at the beginning then, the fundamentals. What are the walls made of? What's the fluid like? And crucially, how do they get their shape, the embryology?
Okay, the ventricular walls. What actually lines these chambers?
It's lined by something called ependema. And it's not just a simple lining. It's a specialized type of glial cell, forming an epithelium. And the really key thing, these cells have tight junctions between them. That's critical, because it means the ependema forms the brain CSF barrier.
Ah, so it's a controlled boundary, not just leaky tissue.
Yeah.
What does that lining do?
Functionally, 2 things. First, the ependymal cells have cilia, tiny hair-like structures, and these cilia beat together in a specific direction. This coordinated beating actually helps propel the CSF, keeps it flowing through the system towards the exit points.
And visually, if a surgeon gets inside, what tells them they're in the right place?
Macroscopically, when you see it, the ependema has this really distinctive, shiny white appearance. It's pearly, almost reflective. Seeing that smooth white surface is the immediate confirmation, okay, I'm inside the ventricle. It's a key intraoperative sign.
Got it. Okay, let's talk about the fluid itself, CSF, cerebrospinal fluid. We know it circulates inside and outside the brain. What are its main jobs?
Right, CSF, it's basically colorless acellular fluid. Physically, its biggest role is protection. It's the brain's shock absorber, a hydraulic cushion. And it also helps manage pressure swings. When you cough or strain, intracranial pressure spikes. CSF helps buffer those changes, protecting the brain tissue.
And biochemically, it's not just packing material.
No, definitely not. Biochemically, it's crucial for transport. It carries away waste products, brain metabolites, and it's involved in maintaining the brain's delicate acid-base balance, which is essential for neurons to function properly.
Now, the classic model of CSF is pretty simple, made in one place, absorbed in another, but the modern understanding is a bit more nuanced, isn't it?
It is, yeah. The traditional view, what we all learned first, was that the choroid plexus, this sort of frond-like vascular structure you find in the lateral third and fourth ventricles, that's where all the CSF is produced. And then it gets absorbed way up top at the arachnoid villi, along the big venous sinuses.
But that doesn't quite explain everything we see clinically, does it?
Not entirely. The more modern view recognizes that CSF absorption, or resorption, is actually happening much more broadly throughout the central nervous system. It's not just the villi. It seems CSF can also be absorbed across capillary walls, maybe via lymphatic pathways, even across the ependema itself. This more complex picture helps explain things like communicating hydrocephalus, where the main pathways seem open but pressure still builds up.
And fascinatingly, this newer understanding actually supports a resurgence of an older surgical technique, right?
Exactly. It brings us back to tackling CSF production directly. We're seeing a comeback for choroid plexus resection, or cauterization, often done endoscopically now. The thinking is if you can reduce the amount of CSF being made, especially when you combine it with a procedure like ETV that opens up a drainage path, you can potentially manage hydrocephalus more effectively in certain cases. Sort of a two-pronged approach.
Before we get into the detailed shapes, we need that why. Why are the ventricles shaped the way they are? Talk us through the embryology.
Okay, the embryology is key to understanding the final relationships. The whole central nervous system starts as a simple tube, the neural tube, with a hollow space inside, the lumen. As the brain develops and folds, different parts of that tube expand and differentiate, and the lumen inside becomes the ventricles.
So which part becomes which ventricle?
Right. The big cerebral hemispheres develop from the front part, the telencephalon. The lumen inside there expands massively and folds into that characteristic C shape of the paired lateral ventricles. They essentially wrap around the developing deep structures. Then the diencephalon, which forms the thalamus and hypothalamus, its lumen becomes the single midline third ventricle. And further back, the rhombencephalon giving rise to the pons, medulla, and cerebellum, its lumen forms the fourth ventricle. Knowing these origins helps you understand why certain brain structures form the walls of specific ventricles.
Okay, so we have the chambers. Now, trace the flow for us. Where does the CSF go? And crucially, where are the common choke points, the bottlenecks?
So the flow generally starts in the lateral ventricles. From each lateral ventricle, CSF flows through a small opening, the paired foramina of Monro, into the single third ventricle.
Those foramina are quite narrow, aren't they?
They are, and from the third ventricle, the CSF has to squeeze through an even narrower channel, the cerebral aqueduct, also known as the aqueduct of Sylvius. This runs down through the midbrain into the fourth ventricle.
And the aqueduct is probably the most famous site of blockage.
It's notoriously narrow, yes. The tightest spot in the system. Once CSF gets into the fourth ventricle, it needs to exit into the subarachnoid space surrounding the brain and spinal cord. It does this mainly through three openings. One midline hole called the foramen of Magendie, which opens posteriorly into the cisterna magna, and two lateral holes, the foramina of Luschka, which open out towards the base of the brain. A tiny bit also goes down the central canal of the spinal cord via the obex.
So clinically, these narrow connecting points, Monro, the aqueduct, Magendie, Luschka, these are the trouble spots.
Exactly. Because they're narrow, they're the most common places for obstruction. Blockage can happen from inside, say, blood clots after a hemorrhage, pus from an infection, or even tumor cells floating in the CSF. Or it can happen from outside, where a tumor or some other mass compresses the channel and squeezes it shut. Either way, CSF backs up upstream, causing hydrocephalus.
Okay, fundamentals covered. Let's get into the specific geography, starting with the biggest players, the lateral ventricles, that big C shape.
Right, the paired lateral ventricles. They really dominate the system. We usually divide each one into 5 parts to make sense of them. The main central part is the body. The big junction where the body, temporal horn, and occipital horn meet is the atrium, or trigone. And then the 3 extensions, the frontal horn pointing forwards, the temporal horn pointing down and forwards into the temporal lobe, and the occipital horn pointing backwards.
Let's start at the front then, the frontal horn. What defines its boundaries?
Okay, the frontal horn is everything anterior to the foramen of Monro. Medially, its wall is the septum pellucidum, that thin, almost translucent double membrane separating the 2 ventricles. Laterally, the wall is the big, bulging head of the caudate nucleus. The roof and the very front wall are formed by fibers of the corpus callosum, specifically the genu, as it curves around.
And here we hit one of those critical anatomical negatives you mentioned earlier. Something that isn't there is key.
Precisely. The single most important navigational fact about the frontal horn. There is no choroid plexus in it. 0. This absence is a huge clue for endoscopy. If you put a scope in and all you see is smooth, shiny white ependyma, you know you're looking forwards. You need to aim down and back to find the foramen of Monro because that's where the choroid plexus starts.
Okay, moving posteriorly along that C-curve, we get to the body of the lateral ventricle, mainly under the parietal lobe.
The body runs from the foramen of Monro back to where the septum pellucidum ends. The lateral wall is still the caudate nucleus. But the floor changes. Now the floor is formed by the upper surface of the thalamus.
And there's a specific landmark dividing those 2 major structures on the floor lateral wall.
Yes, the caudothalamic groove. It's a groove running between the caudate and the thalamus.
Yeah.
And it's important because it contains the saestria terminalis and, more critically for surgery, the thalamostrate vein. Injuring that vein is bad news. It can cause significant deep brain infarcts.
And unlike the frontal horn, the body does have choroid plexus.
It does. The choroid plexus runs along the floor of the body in that groove. And this is another navigational aid. If you find the choroid plexus in the body and follow it anteriorly, it will lead you straight to the foramen of Monro.
Next up, the big intersection, the atrium or trigone.
Right, the atrium. It's where the body connects from above and front, the temporal horn connects from below and front, and the occipital horn connects from the back. It's a major crossroads.
What are the key structures forming its walls, particularly the medial wall?
Medially, you have the bulb of corpus callosum forming the roof upper part, and inferiorly, there's a prominent bulge called the calcar avus. This bulge is created by the deep infolding of the calcarine sulcus, which is part of the visual cortex pathway. So you're near visual structures here.
And this area is also home to the biggest chunk of choroid plexus.
Yes. The atrium contains the most voluminous part of the choroid plexus, known as the choroid glomus or glomus choroideum. Clinically, this is useful because the glomus often calcifies as people get older. You can frequently see this calcification clearly on CT scans, giving you a very reliable internal landmark.
Okay, let's follow the curve downwards now into the temporal horn, deep in the temporal lobe.
The temporal horn, or inferior horn, curves down and forward, ending blindly pretty close, about 2.5 centimeters to the tip of the temporal lobe. Its boundaries are really high-value real estate neurologically. The anterior wall is the amygdala. The floor is made up of the hippocampus, medially absolutely critical for memory, and laterally by the collateral eminence.
So any surgery approaching this horn requires extreme care for memory and emotional functions.
Absolutely. It's delicate territory. Like the body, the temporal horn does contain choroid plexus, which, again, along with that shiny white ependema, helps confirm your location if you're operating deep in the temporal lobe.
And finally, the tail end of the C, the occipital horn pointing backwards.
The occipital horn, or posterior horn, is the most variable. It can be quite small, sometimes almost absent, or it can extend significantly back into the occipital lobe. It's generally triangular. Its walls are mainly formed by fibers of the corpus callosum wrapping around. The medial wall has the bulb and the calcar avus again, and the lateral wall and roof are formed by the tapetum, another layer of callosal fibers. Because it's so variable, it's generally the least useful horn as a consistent surgical landmark. Okay, so we've covered the large, complex lateral ventricles. Now we need to shift focus to the very different challenge of the third ventricle.
Yeah, the third ventricle, it's always described as difficult. Narrow, midline, deep within the diencephalon. Why is it considered so surgically challenging?
It's challenging because of its location and what surrounds it. It's literally sandwiched between the two thalami and hypothalami. Accessing it means navigating past or through incredibly important structures for vision, hormone control, consciousness, memory. The stakes are just extremely high. It really is a kind of anatomical minefield.
Let's zero in on the floor. This is a critical area, especially for ETV. What structures form the floor going front to back?
The floor is key. Anteriorly, you have the optic chiasm. Then moving back, the infundibulum, the stalk connecting to the pituitary gland. Then the tuber cinereum, then the paired pea-sized mammillary bodies, which are part of the memory circuitry. Behind them is the posterior perforated substance, and finally the opening into the cerebral aqueduct.
And are there visible signs on the floor that indicate hydrocephalus?
Yes, definitely. Normally, the recesses in the floor, the little dips near the chiasm and infundibulum, are quite sharp, acute angles. One of the earliest signs of hydrocephalus on imaging is seeing these recesses start to bulge outwards, becoming rounded. As the pressure increases, the whole floor, which is quite thin, can get pushed downwards.
And it's this thin area that surgeons target for ETV.
Exactly. The specific target spot for ETV is a small patch of thin membrane located between the tuber cinereum, anteriorly, and the mammillary bodies, posteriorly. It's relatively avascular and considered safe to puncture there to create that bypass for CSF flow, getting around, say, an aqueduct blockage.
Okay, what about the anterior wall of the third ventricle? There's another safe zone there, isn't there?
Yes, the anterior wall runs from the foramen of Monro down to the optic chiasm. It contains the anterior commissure, but importantly, it also contains the lamina terminalis. And the lamina terminalis is surgically vital because it's a thin membrane that is essentially non-neural. It doesn't contain critical functional brain tissue. It's like the sealed front end of the original neural tube.
So similar to the lack of choroid in the frontal horn, the lack of critical neurons here makes it a useful surgical window.
Precisely. It's another anatomical negative that's surgically positive. Neurosurgeons often open the lamina terminalis not just for ETV-like procedures, but also during open surgery, like clipping an anterior communicating artery aneurysm. Opening it lets CSF out, relaxes the brain, and gives the surgeon more room to work safely around the aneurysm.
And the roof and lateral walls, what defines them?
The roof is complex. Superiorly, it's bounded by the arching fornix, which is crucial for memory. Below the fornix is the vascular layer called the telechoroidea. This isn't simple. It's actually two layers of pia mater enclosing a space, the velum interpositum. And within that space run critical veins, the paired internal cerebral veins, and the medial posterior choroidal arteries. Breaching the roof means entering a major venous danger zone.
And the lateral walls are pure brain tissue.
Purely neural, yes. The upper part of the lateral wall is the thalamus, and the lower part is the hypothalamus. They're separated by a faint groove, the hypothalamic sulcus. There's also a variable structure here called the massa intermedia. It's a bridge of gray matter that sometimes connects the two thalamies across the midline of the third ventricle.
How does that massa intermedia affect surgery if it's present?
It's quite variable, maybe absent in up to a quarter of people.
Uh-huh.
But if it's large, and it can be quite large sometimes, particularly in children with certain conditions like spina bifida, it can literally block the view during endoscopy and sit right in the middle of the third ventricle and make it difficult or impossible to see the floor properly or pass instruments. So you have to assess its size on pre-op scans when planning an endoscopic approach.
Okay, now we descend to the lowest ventricle, the fourth ventricle. You described this earlier as the most hazardous area. Why?
I did, and it's no exaggeration. The fourth ventricle sits between the cerebellum behind and the brainstem, the pons, and medulla in front. Its floor, called the rhomboid fossa because of its diamond shape, is essentially the surface of the dorsal brainstem. And that surface is packed with the nuclei of critical cranial nerves.
Can you map out some of those key features on the floor?
Sure. The diamond shape connects to the aqueduct above, the obex, leading to the spinal cord canal below, and the foramina of Luschka laterally. The floor itself has a midline groove, the median sulcus. Then there are several important bumps or elevations. There's the facial colliculus, which is a bulge made by the facial nerve, CM serofibers, looping over the abducens nerve, CN nucleus. There's the hypoglossal triangle over the nucleus for tongue movement, CN12. The vagal triangle over the nucleus for swallowing and parasympathetic functions, CNX. And the area postrema involved in nausea and vomiting.
The concentration of function there is just immense.
It is. And that's the danger. Any injury, even temporary bruising from retraction, to any of these structures on the floor during surgery, say, removing a tumor can cause devastating problems. Facial paralysis, problems swallowing, double vision, hoarseness, really significant life-altering deficits. Utmost care is required.
What about the roof of the fourth ventricle and the CSF exit point?
The roof is sort of tent-shaped. The upper cranial half is formed by the superior medullary velum, which is neural tissue, but the lower caudal half is formed by the inferior medullary velum and the telechoroidea.
And here's another game-changing anatomical negative.
Exactly. This lower caudal part of the roof is crucially non-neural. It doesn't contain vital brainstem tracts or nuclei. And this anatomical fact is the key that unlocks the modern, safer surgical approach to the fourth ventricle. The CSF exits from this lower region via the midline foramen of Magendie and the lateral foramina of Luschka.
Okay, we've built the detailed map. Now let's apply it to the core surgical procedures, starting with the absolute basic. Inserting a ventricular catheter, an EVD.
Right, the external ventricular drain. It's a fundamental skill, often done emergently. While we have navigation technology now, knowing the classic landmarks is still essential.
So let's nail those landmarks for Kocher's point.
Kocher's point is the standard entry site for hitting the funnel horn of the lateral ventricle. The burr hole is typically placed 1 to 2 centimeters anterior to the coronal suture, in line with the mid-pupil, usually on the right side unless there's a reason to go left. But the entry point is only half of it. The trajectory is everything.
How do you aim it correctly without seeing inside?
You aim the catheter towards an imaginary intersection point deep inside. Think of a line going straight back from the inner corner, medial canthus, of the eye on the same side, and another line going straight in from the little cartilage bump, tragus, in front of the ear on the same side. Where those lines cross in 3D space, that's your target. Aiming that way should land the catheter tip right near the foramen of Monroe, usually about 5 to 7 centimeters deep from the skull surface in an adult.
Okay, beyond just draining CSF, let's talk about getting into the frontal horn or body for tumor surgery. 2 main routes, transcallosal and transcortical. What are the trade-offs?
The anterior transcallosal approach goes between the two hemispheres and cuts through the corpus callosum. It's a big advantage. You don't cut through the cerebral cortex itself. This means a lower risk of causing seizures or neurological deficits from damaging the cortical surface. It works well even if the ventricles aren't enlarged, and it can give you access to both sides if needed.
What are the downsides or risks of going transcallosal?
Well, the corridor is naturally quite narrow, working down between the hemispheres, and there's a risk of damaging the bridging veins that drain the brain surface into the big sagittal sinus running along the top.
Can you briefly outline the technique?
Sure. You gently retract one hemisphere, find the gap between the two pericallosal arteries running on the corpus callosum. Then you carefully divide the corpus callosum itself, that bright white structure, for maybe 20 millimeters or so. Once you're in the ventricle, if you don't immediately see the foramen of Monro, you look for the choroid plexus or the thalamostriate vein and follow them forwards. They'll lead you right to it.
Okay, now the alternative, the anterior transcortical approach. When would you choose this, and what's the major drawback?
The transcortical approach goes directly through the cortex into the ventricle. It gives you a wider angle, which is better for tumors that spread out laterally into the hemisphere, and it's actually much easier if the ventricles are already enlarged from hydrocephalus, because the brain tissue is thinner and you don't need to retract as much.
But the drawback is significant.
It is. It's the main reason to avoid it if possible. You have to make an incision in the brain cortex. Usually it's done in the middle frontal gyrus, which is considered relatively silent function-wise, but any cut in the cortex carries a real risk of causing seizures later on or potentially a neurological deficit. It's a direct trade-off. Easier access versus higher neurological risk.
Let's shift back now to the atrium or trigone area. This region has its own specific set of neurological risks, particularly visual and language related.
Absolutely. Operating around the trigone is tricky. Take the transtemporal approach coming in from the side through the temporal lobe. It gives direct access, but it goes right through the optic radiations of fibers carrying visual information back to the occipital cortex. So there's a high risk of causing a visual field defect. And you absolutely wouldn't use this approach on the dominant side of the brain because you're too close to critical language areas.
What about approaches from the back? How do they balance the risks?
There are a few options. The posterior transcallosal approach, again, avoids cutting cortex, but splitting the back part of the corpus callosum, the splenium, can cause specific disconnection syndromes. The classic example is alexia without agraphia. The person can still write normally, but they can't read, not even what they just wrote.
And the occipital approach, going through the occipital lobe itself.
That gives good access, especially for things near the pineal gland or deep in the medial occipital lobe. But retracting the occipital lobe carries a very direct risk of causing serious visual problems, maybe even cortical blindness or large field cuts.
Finally, the posterior transcortical approach for lesions in the posterior body or atrium. You remembered a specific vascular hazard here.
Yes, this is a classic problem, especially with vascular tumors like choroid plexus papillomas, which are common in the atrium. If you come in through the cortex transcortically, you're dissecting down towards the tumor. The tumor's blood supply comes from deep choroidal arteries. This means you encounter the main feeding arteries last, only after you've already mobilized much of the tumor. This creates a risk of sudden, massive bleeding right at the end of the resection, which is very difficult to control. Often these tumors need to be embolized preoperatively to reduce that risk. Right, moving on to the really deep territory. The third ventricle. Access here almost always requires advanced tools like image guidance, endoscopy, because it's so tightly packed with vital structures.
Let's outline the open approaches first, the subfrontal translamina terminalis approach.
Okay, this approach uses that non-neural window, the lamina terminalis. It's great for lesions in the front bottom part of the third ventricle, like craniopharyngiomas. You work between the frontal lobes, interhemispheric, carefully dissecting between the bottom of the corpus callosum, the rostrum, and the complex network of vessels around the anterior communicating artery. Opening the lamina terminalis gets you right into the front of the third ventricle.
Then there are the two main routes through the top, via the corpus callosum. First, the transcallosal interfornical approach.
This is generally considered the safer of the two transcallosal routes to the third ventricle. After opening the corpus callosum, the surgeon carefully finds the natural plane between the two columns of the fornix. The goal is to gently separate them without injury, protecting those crucial memory pathways. Then you open the roof of the third ventricle just between them to get down to the floor.
And the alternative, which you noted, carries more risk, the transcallosal transchoroidal fissure approach.
Yes, this is usually for lesions further back in the third ventricle. Instead of going between the fornices, this approach involves opening the choroidal fissure, which means working right alongside the fornix, and potentially manipulating the internal cerebral veins within the roof membrane, the telechoroidea. It might give a bit more room, but the risk of damaging the fornix or those deep veins is definitely higher.
What about lesions right at the very back of the third ventricle near the pineal gland? How are those typically accessed?
For those posterior lesions, the standard route is actually from below and behind, the infratentorial supracerebellar approach. You come in underneath the tentorium, the membrane separating cerebrum and cerebellum, and above the cerebellum. Often, surgeons do this with the patient in a sitting position because gravity then helps the cerebellum fall away gently, reducing the need for potentially damaging retraction.
Okay, now let's focus on the endoscopic workhorse for hydrocephalus. Endoscopic third ventriculostomy, ETV.
ETV has been a real game changer. It offers the chance to treat hydrocephalus without implanting a permanent shunt system. Avoiding all the long-term problems, shunts can have blockages, infections, overdrainage.
Importantly, the entry point on the skull is slightly different from the standard EVD entry point.
It is, yes. For an EVD, we use Kocher's point, which is 1 to 2 centimeters in front of the coronal suture. For ETV, the ideal entry point is usually right on the coronal suture, still in the mid-pupillary line. That slight posterior shift gives the endoscope the perfect angle to go through the foramen of Monro safely without hitting the fornix, and then look straight down at the floor of the third ventricle, where the opening needs to be made.
Once the endoscope is inside the third ventricle, what are the key landmarks the surgeon absolutely must identify before making the hole?
Right. Orientation is everything. After passing through Monro, carefully avoiding the fornix, you need to clearly see the landmarks on the floor. Anteriorly, you look for the bulge of the infundibular recess. Posteriorly, you identify the paired, whitish bumps of the mammillary bodies.
And the precise target lies between those. What's the main danger lurking just beyond?
The target is that thin, often translucent membrane right between the tuber cinereum, just behind the infundibulum, and the mammillary bodies. You perforate that membrane. The huge danger, the structure you absolutely must not hit, lies just deep to that spot. The basilar artery. It's a major artery supplying the brainstem, often visible pulsating deep red through the floor. The perforation has to be controlled and shallow to avoid catastrophic vascular injury.
Finally, let's tackle the approaches to the fourth ventricle. We need to contrast the older method with the modern anatomy-driven technique.
Okay. The traditional way to get into the fourth ventricle, especially the upper part, was the transvermian approach. This involves splitting the cerebellar vermis, the midline part of the cerebellum, down the middle. It gives good exposure superiorly, but it came with a significant, often devastating complication.
That complication being cerebellar mutism.
Exactly. This is a really feared problem. It's thought that retracting the cerebellar hemispheres during this approach, especially impacting the deep dentate nuclei, can cause this syndrome. It often starts a day or two after surgery. The patient becomes mute, can have other cranial nerve issues, becomes emotionally flat or withdrawn. Recovery can take months and isn't always complete.
So the high risk of mutism led surgeons to find a better way.
Precisely. The understanding of the fourth ventricle roof anatomy led to the Lovler approach, which is now generally preferred. This approach exploits that anatomical fact we discussed earlier. The lower part of the roof, the inferior medullary delichoroidea, is non-neural.
So the surgeon uses that safe zone to get in without cutting brain tissue.
That's the principle. The surgeon works in the natural cleft between the cerebellar tonsil and the uvula, parts of the cerebellum, and then opens up this non-neural roof membrane. The big advantages are a much lower risk of causing cerebellar mutism or ataxia, coordination problems, and it actually gives better exposure of the floor and the lateral recesses where the foramina of Luschka are. It's a more elegant, anatomy-respecting approach.
This whole journey really underscores how deep anatomical knowledge translates directly into safer surgery. Let's try to synthesize this. What are the absolute core principles for operating in or around the ventricles?
Well, the number one principle, really for almost all intracranial surgery, is that you need CSF egress. You need to let CSF out, either by opening the dura, opening cisterns, or inserting a drain like an EVD. Why? Because draining CSF reduces the total volume inside the skull, which allows the brain to relax. A relaxed brain requires less retraction, and less retraction means less risk of swelling, bruising, or even stroke caused by compressing the brain tissue and its blood supply. Patience here is key. Letting the brain relax naturally is safer than forcing it with retractors.
And let's quickly recap the three major site-specific hazards we've highlighted, the things that define surgical risk in these areas.
Okay, three big ones. First, Any transcortical approach, going through the brain's surface to reach the lateral ventricle, always carries that long-term risk of postoperative epilepsy because the scar can become irritable. Second, operating on the floor of the fourth ventricle, the rhomboid fossa, risks direct injury to cranial nerve nuclei, leading to potentially severe cranial neuropathies. And third, injury to the dentate nuclei deep in the cerebellum, often from retraction during posterior fossa approaches like the older transvermian route, can cause cerebellar mutism.
Avoiding those is really the mark of expertise. Let's make this concrete with our clinical example. The 56-year-old woman with a subarachnoid hemorrhage, SAH, who develops acute hydrocephalus.
Right. So first things first, she needs that pressure relieved urgently. That means an EVD insertion. We use Kocher's point. Aim for the foramen Monroe. Get the catheter in to drain the CSF that's backing up because blood clots are blocking the normal pathways. That stabilizes her acutely.
Then she goes for surgery to clip the aneurysm, which was likely an anterior communicating artery aneurysm in this scenario. What specific maneuver, using the anatomy we've discussed, might the surgeon perform during that clipping to potentially help her avoid needing a permanent shunt later?
During the aneurysm surgery, while they have exposure at the base of the brain, the surgeon will often deliberately open the lamina terminalis. We know it's thin, avascular, non-neural. Puncturing it creates a direct connection, a new pathway for CSF to flow from the third ventricle straight out into the basal cisterns. The hope is that this bypasses any blockage caused by blood clots lower down and might prevent her from developing the chronic communicating hydrocephalus that often requires a long-term shunt after SAH. It doesn't always work, but it's an attempt to use anatomy to prevent a later complication.
So reflecting on this whole deep dive, what's the takeaway for someone striving for that elite level? We've journeyed through the lateral ventricle's 5 regions, the tight confines of the third, the dangerous floor of the fourth.
I think the takeaway is that true mastery isn't just knowing the names of the parts, it's understanding the quality of the boundaries. Is this wall vital neural tissue I must protect at all costs? Is this wall a major vein I have to navigate around? Or is this wall, like the lamina terminalis or the lower fourth ventricle roof, a non-neural safe corridor that I can actually use to my advantage? It's about differential risk assessment based on deep anatomical knowledge.
It really seems to boil down to recognizing the significance of subtle details, sometimes even what isn't there. The lack of neural tissue in the caudal fourth ventricle roof wasn't just trivia. It fundamentally changed the surgical approach, making the Telleveler method possible and safer.
Exactly. And similarly, the absence of choroid plexus in the frontal horn isn't just a footnote. It's a crucial "you are here" sign for the endoscopist. Knowing what's missing is as important as knowing what's present.
Which brings us to our final provocative thought for you, the listener. We saw today how these anatomical negatives, the absence of something, can be powerful positive guides in neurosurgery. Think about other areas of the body, other high-stakes professional fields. Where else does the recognized absence of a specific structure, tissue type, or even a signal serve as a critical landmark or a safety indicator that enables precise and safe action? Something to ponder. Thanks for joining us for this deep dive.